pertinent topic. And I have with me the co-chairperson, who is Dr. Chiu Ming Tuk from Singapore, and welcome to our place, sir. And I'm sure that we'll have a great round over here. The very first session, the first plenary session, we will be having presentations from 4 different countries. And the very first is from Indonesia. But before that, just a few opening remarks from Dr. Tuk, please.
Thank you. I think it's a very important session where we get to learn from each other, all the different systems, and as Dr. Nitin has alluded to, we have presentations from 4 different countries, and we'll have an opportunity to see how trauma is managed in these 4 different countries. So we'll introduce our first speaker now.
Thank you very much. The first speaker is Dr. Yuti Suharti. She is Director of Directorate in Nursing and Allied Healthcare from Indonesia. And we'll be hearing about sharing the experience in trauma nursing and Indonesian experience. Dr. Suharti, please. Welcome.
Bismillahirrahmanirrahim. Mr. Chair, distinguished delegates, ladies and gentlemen, on behalf of the Directorate of Nursing and Allied Healthcare, Ministry of Health of the Republic of Indonesia, we would like to thank and appreciate the Ministry of Health and Family Welfare of India and also the All India Institute of Medical Sciences to conduct roundtable collaboration in trauma care and nursing within EAS as Summit framework in New Delhi, now until tomorrow. Yes, as we know, Indonesia location places at a high risk of natural disaster. 3 of the world's 9 tectonic plates come together under the Indonesian archipelago. Even slight movement of any of them tends to trigger an earthquake. Major slippage can set off earthquakes under land or sea, ultimately releasing tsunamis such as the one that hit Japan last, and Indonesia and many other countries of our region in 2004. At the same time, Indonesia is also located at the western and on what is called the Ring of Fire, home of the vast majority of the world's active volcanoes, and 126 of which are in Indonesia. This combination of geological factors causes Indonesia to experience an average of 5 earthquakes rating at least 5 on the Richter scale each day. Besides earthquake, many things that cause trauma and injury in Indonesia, such as development and increased industry, urbanization, social conflict, disaster cost of human. And then injury rate increased from 7.5% in the year of 2007, now become 8.2% in the year 2013. The highest cause are fall and motorcycle accident, like India cause. And then the death rate caused by traffic accident was very high. Yes, like in the slide, 31,000 and more percent. Incident of fracture was 11.3 of 1,000 per year. And the accident of head injury were hospitalized 70 to 70% with mild, and then 15 to 20 moderate, and then 10% by severe. In addition to the above mentioned, Post-traumatic stress disorder and sexual abuse become issues which require specific treatment. Ladies and gentlemen, Indonesia has regulation as a basis for implementation, trauma management, that is health law, hospital law, medical practice law, nursing law, and also national guideline or minister decree of management of health crisis. Indonesia also has a policy and program for the disaster management in hospital following a health crisis center strategic plan, and then establishment of 9 regional crisis center and 2 sub-regional crisis centers, and then disaster management program in a hospital through hospital accreditation, and integrated trauma and disaster management system, both in a daily condition or in a disaster. We call SPGDT S and SPGDT-B. Yes, here we show you that regional crisis center. We like I said that there are 9 regional. Indonesia has 9 regional crisis centers to have better coverage of trauma and disaster management across Indonesia. Established at the end of 2006. The regional crisis center are equipped with the logistic equipment and personnel necessary for prompt and then professional disaster management. The location are as follows: East Sumatra, East Java, Bali, South Kalimantan, North Sulawesi, and South Sulawesi, 9 regions. And then integrated trauma and disaster management system, like I say that we call SPGDT, is a system comprising of the following components: pre-hospital to hospitals and between hospitals, use of communication technologies, telephone, radio communication, and so on, and then transportation, ambulance, handling by human resource and involving multiple sectors, and also communication and informatics, telecom, local government, and hospitals. Yes. This program is intended to save the lives of victims or patients. It has been implemented in several areas, like I said, in Medan and so on, Medan, Jakarta, Bandung, and so on. Currently, call center 9119 is being prepared to support SPGDT that can be accessed nationally. Yes. Previously, virus number is province, but now only one number 119. Yes, safe community is a safe and healthy environment that is created from, by, and for the community. Public facilities that should be strengthened are a mix of availability of emergency ambulance, and then security by the police, and then safety or fire safety by the fire brigades. Government and technocrats are facilitator and mentors. The first one in the trauma center, which the services performed by several specialists such as surgeon, anesthetist, and nurse specialists, and provide advanced trauma life support equipment quickly ready in 24 hours. Handling of trauma patient in the trauma center supported multiple installation and services unit host activities are mutually supportive. Installation and support units trauma center, among others, like I say, ambulance, the emergency rooms, laboratory, radiology, operating rooms, intensive care unit, medical rehabilitation unit, and then pharmacy and forensic. Yes, ladies and gentlemen, in this slide show that, this network of trauma and disaster networking. Yeah. Launch of SPGDT involve multiple sectors, like I said. Launched in 2012 in Medan, Jakarta, Bandung, Denpasar, Manado, Makassar, and Yogyakarta. SPGDT is a system consisting of the component of pre-hospital, hospital, and inter-hospital communication, transportation, health, human resource, and involving other sectors. Yes, here show us that daily service of pre-hospital includes emergency service response, and then ambulance services, and then communications, medical radio communication, and then development or skill training. Yes, here show that integrated care for trauma patient. Sorry, yes. For trauma patient implemented by referral system. Yes, by referral system from PAC until tertiary level. Primary health care here, and then secondary level, and tertiary level with qualification of health team should be suitable with level of a hospital. Yes, here in primary health care conducted or served by general doctors and nurse with emergency certification. And then in the secondary level, conducted or served by surgical doctors and nursing with emergency certification or nurse specialist in a surgical. And then in third level or tertiary level, conducted or served by surgical doctor, medical doctor, anesthetic doctor, neurologic doctor, psychiatric and psychiatric doctor, psychiatrist, and nurse specialist in surgical and critical nurse. Yes, trauma management in hospital. In the trauma center, with the service performed by several specialists, like I say, handling of this services conducted on 24 hours. Handling of trauma patient in the trauma center supported multiple installation and services unit whose activities are mutually supportive. Installation and support unit trauma center, among others, ambulance, the emergency room, laboratory, radiology, operating rooms, intensive care unit, rehabilitation unit, and pharmacy and forensic. Yeah. Here consists of medical support and also management support. And then here the roles of trauma nursing in Indonesia. Is the trauma nurse should be able to manage nursing care, such as conduct rapid assessment to determine the needs of nursing service in the area of trauma, and then perform triage trauma, and also the third one, conduct safety referral to prevent complication of trauma, and the fourth one, collaboration with all health team to achieve integration services. And fifth one, analyzing and making priority intervention or priority treatment. And then sixth, preventive and infection control. And the seventh, educate the public related to stabilization and evacuation. And then handling trauma with trauma treatment and intervention. And then implement of continuing of care. Yes, here describe about the improving capacity for the doctor and nurse especially. To improve capacity for doctor and nurse in trauma management and services, it has been taken some program and activities such as peer group assessment and examination between senior or the same level practitioner in the hospital or across hospital. And then training on trauma or disaster. And then the third one is beside examination or bedside teaching from senior to junior practitioner. And then also coaching. And then TOT or BTLS and ACLS minimum. Yes. Ladies and gentlemen, I think that's all. Yeah, our presentation. The presentation is the implementation of trauma and disaster management in Indonesia. Thank you for your attention. We hope the information provided us useful. Thank you very much.
Thank you, Dr. Suharti. We'll leave the questioning to the end of the session. So without further ado, we'll move on to our second presenter, who is from New Zealand, Ms. Jane Cunliffe. She's from the New Zealand High Commission in India, and she'll give us a presentation on trauma situation in New Zealand.
Mr. Chairman, should I start or? Sorry. Kia ora, namaskar. Greetings from New Zealand. I bring also best wishes from our High Commissioner, Mr. Graham, His Excellency Graham Morton, who could not be here today because he's outside New Delhi. But I'm very pleased to be present today, and we are very, it is very poignant, I should say, that this conference, this East Asia Summit, of which New Zealand is a key participant, a keen participant in the East Asia Summit, where it's very poignant to us that this event has been hosted here at the All India Institute of Medical Sciences because New Zealand back in 1952 gave a £1 million grant, which was the founding donation that helped the establishment of AIIMS, and we're very proud that we've been part of we've been part of that initiation, and that we see this wonderful institute today. The New Zealand healthcare system, like many others, is largely public funded, and we face most of the same issues that the healthcare systems around the world do. Our health practitioners and our emergency services have done quite a lot of work in the past on trauma and emergency response, particularly with respect to road accidents and search and rescue. And we've had pretty good success rates in reducing road accidents. But to this meeting, I bring just three very brief key messages from our Ministry of Health. I profess and apologise that I'm not the expert here, and indeed we regret and apologise that we could not get anybody from our Ministry of Health to be here. But thank you for hosting me instead. The three messages that I would bring from our Ministry of Health. They say, firstly, health targets are a means of developing faster access to important services, and in 2009 New Zealand introduced an emergency department target of patients being admitted, transferred or discharged from the emergency department within 6 hours. In 2009, 80% of patients were being admitted, discharged or transferred from the emergency department within 6 hours. Today, 95% of patients are being admitted, discharged or transferred within 6 hours. So this has been achieved despite increasing numbers of emergency presentations. The second point that we would make is that trauma nurses have a role in reinforcing the work of clinicians in primary care to protect and keep people safe. Brief interventions, including alcohol, smoking and family violence screening, at times when people interact with the health system, can be powerful to enable people to get the help they need to keep them safe or make change in their lives. The third point that we would make would be that preparing for the future population health needs will require harnessing the full potential of the workforce. There are highly skilled and experienced nurses working in trauma care, and it's important to ensure there are no barriers to these practitioners working to the full extent of their knowledge and skills. This includes utilising clinical nurse specialists and nurse practitioners' roles. Just to conclude, I mentioned before the success we'd had in reducing road accidents through quite a lot of work through the Ministry of Transport and the Ministry and the Police Department, and it has been quite, and I know from Professor Mishra, this is a very important consideration here as well in the preventative approach. So we have, through a number of different mechanisms and strategies, done well at reducing road accidents, and indeed we have people assisting a World Bank project in Uttar Pradesh on setting up a road patrol force. So without further ado, I'd just like to bring best wishes from New Zealand to this very, very important summit here today, and thank you for your time.
Thank you very much, Ms. Jean Cunliffe, and giving the point of view from New Zealand. And we move to the next speaker. It's from Japan. We have Mr. Yasuro Sensho, who is the first secretary from the Embassy of Japan here in New Delhi, and he will be speaking on the introduction of emergency medical systems and disaster medical systems in Japan. Mr. Sensho, please.
Good morning, everyone. I'm very pleased and honored to be given this opportunity to share the Japanese system to the Indian specialists, including APEX Institute, AIIMS, and other medical institutes, as well as EAS participant country here. So, first of all, I'd like to emphasize the universal health insurance in Japan. So any medical system is supported by universal health coverage insurance. So 80% of the medical facility are run by private sector, but including the private sector, so 99% of the medical facility is under national health insurance system. So our emergency medical system and the disaster medical system involve the private hospitals also. So this is a feature of the emergency transport system in Japan. Time needed for arrival on the spot and the transfer by ambulance. So in case of emergency, the people call number 119, like a 108 in India. From the call to on-site arrival or a rescue squad in ambulance, it takes 8.5 minutes at national average. And from emergency call to hospital arrival is 93.3 minutes at national average. The number of ambulance dispatch cases and the number of persons transported both increased year by year. The latest emergency dispatch cases is up to 6 million all over the country. So this is a proportion trend of emergency dispatch call for trauma cases in Japan. The share of sudden illness is gradually going up. In the meantime, the share of traffic accident is going down, thanks to the restriction of the traffic rule and technology innovation on road system and automobiles. And so if we see the age-wise, the cases, older people aged 65 or more is increasing, reflecting our aging society. And the share of severe cases is decreasing. This is a structural chart of the emergency medical care system in Japan. So we have 3 tiers. The top of the pyramid is a tertiary care center. The middle is a secondary. The bottom of the pyramid is early stage emergency medical care. So see the top of the pyramid. Emergency and critical care center accept all severe emergency patients 24 hours a day who are in severe condition or requiring treatment in multiple clinical areas. So we have 275 centers in the country. Japan's population is 120 million. So it's 1/10 of Indian population. So secondary care center, multiple hospitals with a secondary medical area accept a severe emergency patient requiring hospitalization on a rotation basis on holidays and during night time. We have up to 3,000 hospitals in secondary care. And a base hospital with a secondary medical area make available part of them and accept severe emergency patients requiring hospitalization on holidays and during night time with a cooperation of doctors in the region. So see the bottom of the pyramid. Multiple doctors on standby at home on a rotation basis within a district or city. Medical association accept relatively mild emergency patients on holidays and during night time. Emergency medical centers established by municipalities accept relatively mild emergency patients on holidays and during night time. In daytime, the week from Monday to Friday, all medical facilities are functional. So once emergency incident occur, some people called 119 for ambulance, and the ambulance come to the on site within 10 minutes at average. And at first, rescue squad dispatched by ambulance investigate and evaluate the patient condition, and if needed, the life-saving technician do life-saving care before transportation to the hospitals. And according to the patient's condition, ambulance decided the hospital to be dispatched. In severe case, the patient will be transported tertiary care centers. And these emergency care centers do treatment and transfer to the higher level hospitals if needed. After emergency care, the patient will be shifted to specialized hospitals if needed. And the patient will be given the treatment or rehabilitation. I will skip this. This is a structure to streamline emergency transport system in each area. So each region is supposed to set up the regional medical control councils in order to improve the life-saving rate and the progress of ill or injured patients. So this medical control councils consist of medical institutions, district or city medical associations, of fire services. Fire services provide the emergency transport system. So fire services are also involved. And prefecture government, health department, and the fire department, etc. The role of this council is number one, a formulation of operation protocol. Number two, instructions, guidelines, and advice by doctors. Number three, follow-up review of emergency activities. Number four, education of etc. And higher level council, a prefecture level council give the advice, technical advice to the regional council. National level council do promotion of information sharing and exchange of opinion between relevant institutions nationwide. We have the system of national license for life-saving technician. It's not a nurse, it's not a doctor. So life-saving technician can do the life-saving care on site of the disaster or traffic accident, etc.